So welcome today to Dr. David Buck, dentist and orthodontist based in USA. Do you want to give yourself an introduction, Dr. Buck?
Well, I have 38 years clinical experience. I've been an educator for many, many years, 25 years plus, and I've went from general practice to orthodontic practice, attaining a master's degree in craniofacial orthopedics and neuromuscular orthodontics from a European accredited university, actually. So by definition, I cannot call myself a specialist in the United States. I didn't do an American residency. I did a European program. But my practice went from extensive restorative, adult-centered practice, cosmetic, restorative, neuromuscular, TMJ, to a fresh start 10 years ago, 2016, as a orthodontic practice, TMJ orthodontic airway practice at that point. Right. And now I'm focused on mostly treating children and then, of course, adults with TMJ problems with using an orthodontic solution as well.
Right. Yes. So that's why I wanted to talk to you, because of your expertise in all these areas and our shared belief, actually, that there's this pandemic or epidemic going on of sleep disordered breathing, which actually starts in childhood. So what would you say about that?
Yeah, it's under-recognized. There's kind of unusual statistical analysis. And I think the numbers are off because you can look at sleep metrics in terms of apnea, hypopnea, that's the standard index, but you need to look at arousals as well and fragmentation of sleep. So a particular child can have maybe not apnea, hypopneas, but they can have unusual arousals going on that relates to airway resistance. And so this whole terminology, upper airway resistance syndrome, that's very apparent in many TMJ patients in adults and in children, effectively is corrupting sleep. And it's my belief is every child, with the technology we have today, this screening technology, using a finger sensor, very non-invasive, very non-obtrusive, with a Bluetooth link to your phone, using a peripheral arterial tonometry signal, which is the signal algorithm used by WatchPat, which has been studied extensively. So I prefer to use a PAT signal in a very small a sleep tracking device, and we can do screening studies and find out if children are having dysfunctional breathing. And I think in the larger picture, I really do feel like every child, as a part of a wellness check and a part of their journey when they enter into the medical community, should have a sleep study, as well as they have a blood draw for any number of blood work panel analysis. There should be a sleep study. There's no reason not to do it with the minimal cost and minimal invasiveness and have that screening done, because of how important we now understand in the longevity community that sleep is usually recognized as number one or two things you need to optimize during your life journey if you're going to maximize your health span and lifespan.
Yeah, for sure. That's interesting that you mentioned the RDI, or the respiratory distress index, being more sensitive and accurate than the AHI in pediatrics as well. That's also something I've seen in young adults, before 18 to 35 or 40 even. That's still the same situation. You're seeing much higher rates of high RDI than AHI, and then as you get older and older, excluding if you're very overweight, in those populations, but just with the aging process, we're seeing this, your neurological sensitivity decrease, so your RDI is decreasing, and then your AHI is starting to go up a lot when you get past a certain middle age period.
Very important. I mean, that makes sense so much logically. When a child starts out with sleep disordered breathing, you wouldn't expect to find central apneas, right? But as the disease progresses, the system becomes more and more dysfunctional. And in that presentation of untreated disease, you might expect to find a central apneas where the brain is failing to signal to breathe. And you find less and less responsiveness to the airway changes, the collapsing of the airway, and you might have then apneas and hypopneas. But airway resistance would be upper airway narrowing during deeper states of sleep, causing an arousal to happen. Of course, we don't have a desaturation event but we have a
Yep.
very fragmented sleep state, which is going to damage. We now understand from some great research, you cannot have insufficient REM sleep. In fact, in animal studies where they intentionally deprive animals of REM sleep, they all die in a short period of time.
Oh,
Just
wow.
remarkable how important REM sleep is and what happens during REM sleep, which is really sleep for the brain. And non-slow wave deep sleep is sleep for the body when the body is growing, when there's growth
Right.
signaling going on. And so it's logical again that the majority of growth is occurring during sleep. Reparative functions and growth, of course, are occurring during sleep. So the jaw growth is a part of that system. If you are not getting proper growth signaling, you're going to have inadequate jaw growth, because of corrupted airway function.
So it's also the actual, do you think, because there's not much correlation between height and recessed, incompletely grown jaws. Do you think there's some sort of specific signaling where the jaws are more responsive in that way because it's the airway itself that, that's separate from overall body height?
Well, this goes into kind of an epigenetic thinking. Jaw growth, it's still a debate. I don't understand why. The evidence is so abundantly clear. Jaw growth is not genetically determined. The actual craniofacial skeleton grows by function of the soft tissues on it. So if you just look up aglossia, which I have a post on my Instagram, it's kind of a prima facie evidence. If there's no tongue, the jaws will not grow. The laps.
Wow.
So it just emphasizes that the jaws grow by how you swallow, how you breathe, what you do with your tongue, and where your tongue rests.
Yeah.
And so if you're sleeping and you have corrupted breathing, meaning you have mouth breathing, then you're actually signaling the body to remodel structures to facilitate mouth breathing in a sense, because air itself is a functional matrix. When you breathe through the nose as a child, you roughly breathe, 1 liter per minute. We know as an adult, you roughly are breathing 7 liters per minute. So that change in the volume of air moving through the nasal cavity is a very important primary growth stimulus for the midface.
Right. Very interesting.
And if we don't have that signaling, the midface will fail to develop. There are some other issues we can talk about the midface growth, but air is a functional matrix and the jaws are going to grow or not grow based on function. The one thing that is never coming back is the consistency of our diets is never going to shift back to our hunter-gatherer predecessors. We don't chew with the kind of force and toughness in the diets that is going to produce additional growth stimulation. So that's gone. It's never coming back. So we're left with tongue posture position and swallowing, and then nasal breathing becomes the big growth stimulation for the midface, which affects the whole jaw structure.
So given the difficulties with diet and having those super tough food diets in the first 10 years or so of your childhood, do you think having perfect nasal breathing is sufficient to create that 100% jaw growth as we saw historically? Or do you think it's more a case of
that's a great question. That's a great way.
Some appliance in some way?
Yeah, I think you can't, if you let go of chewing, you have to have rest oral posture. This is the weird loop we get in. So if you have poor nasal breathing because of low tongue posture, so you have some mixture of mouth breathing and nasal breathing, the palate will collapse very quickly. As the palate is underdeveloped, the tongue no longer can suction seal to the roof of the mouth, and the growth signaling is further corrupted. So it's kind of a mixture. Nasal breathing is very important, but it has to be coupled with absolute full tongue to palate suction seal. We title that rest oral posture. Dr. John Mew really discovered that principle. It's not embraced. It's not taught at all in orthodontic programs, but it's very, very important. So the shape of the palate, the size of the palate will determine if that tongue can be conditioned to be strengthened, but it sits all the way against the palate. And if you have correct oral posture during sleep, it actually suctions to the roof of the mouth, which pulls the lips together, and the tongue will stay out of the airway. So sleep
Yeah.
is tremendously
Right.
improved if
Right.
the tongue is absolutely
Mm.
postured into the palate. But the numbers we look at for that are different than the other standard numbers. All of the metrics for arch development are based on corrupted mid 20th century populations, and they're based on, is there enough room for teeth to be aligned
Uh,
within the dental arch form? There's another way to look at that. Primarily Corricini's work in anthropology showed us that the intermolar width in non-affected or non-industrial or pre-industrial populations was much larger than our metrics created after in the mid 20th century when orthodontic metrics were created.
right. How much larger, do you know?
Well, so if you look at work of McNamara as one of the principal major figures in orthodontics, he would say that, and they measure from different locations.
Yeah.
So you have to kind of, it's a little confusing, but if we take the intermolar width from the upper first permanent molar, that's called the 6,
Yep.
at the gingival level where you're getting more of an alveolar state, not the tooth tipping, you have more of a bone
Yeah.
reference point. The
Lingual side,
conventional metrics,
gingival level.
if I translate that, would be somewhere around 33, 34 millimeters. And Corricini's work looked at the same reference point. He would say 38 to 42 millimeters is
Oh,
much more
okay.
the norm.
Yeah. And
So
do you
anything
think,
below 38, 39, the tongue
yeah,
is going to have a very difficult time having the full
right.
adaptation to the palate.
And that's for adults
Yes.
side. And then the reference ranges will be similar, but different for pediatrics, right?
Well, slightly different. When you have the facial growth trajectory is about 65, 70% of the face is the craniofacial structure develops by age 6, 7, 8. So there isn't a lot of craniofacial growth left between the turnover point between primary dentition, mixed dentition. There isn't a lot of growth left. So you can expand to the adult, when the adult permanent molars come in at 6 or 7, you can skeletally expand to the adult expected final number, which will actually facilitate better breathing, better posture of the tongue, and overall better support for the oral cavity.
And skeletally expands in peds, you're referring to anything in particular?
Well, so we know that we look at 2 categories of growth stimulation. We can do sagittal forward growth stimulation. Another major element, I kind of have rejected the notion that the premaxilla is not present in Homo sapien in our human population. There's really good recent evidence that it's actually present. The sutures are in the premaxilla. We do have a premaxilla in utero, and embryologically it's present. It's a separate fusion line between the upper lateral incisors. So it's the 4 incisors, the upper lip, the philtrum, and the part of the nasal septum is an integrated structure that's evident absolutely embryologically.
Right.
But because it effuses and apparently it becomes not evident by adulthood, we neglected to have anything to say about that. But there is evidence, skull evidence, that even in adults, there's remnants of the suture. But even if a suture fuses in the premaxilla, there's still a stem cell population. There's still a different biological response to stimulation. All that to say that we can do forward growth stimulation in the younger ages, and then we can do transverse development. So forward growth stimulation is kind of a 3-dimensional effect. And I published a paper on this. It's an open access research paper. And then you can do transverse development, which we've done for years, but we've neglected to embrace it in the orthodontic community because some very faulty research told us that expanding early and doing early phase 1 treatment doesn't result in any benefit. So the summary of that limited body of research that was actually not very well done is that there's no benefit to phase 1 early interceptive ortho. So the vast majority of specialists do not do much in the 4 to 9, 10 age group.
Yeah. The phase 1 being that age group?
Initial skeletal facial orthopedics growth. So what should be in that mix should be a sleep study, a screening sleep study. Should be done by the orthodontist, read by a physician. My studies are read by a physician, a board-certified sleep physician. So it's all technically diagnosed correctly. And then doing if it's indicated, doing early jaw development and myofunctional coaching training as well, and identifying if there's obstructed airway problems, nasal cavity, or obviously tonsil adenoid issues as well.
Yeah. And so we've talked about the kind of pediatric situation now. Why do you think so many adults have been missed in terms of airway, sleep apnea, upper airway resistance syndrome, sleep disordered breathing in general? Why do you think so many have been missed? And why has it always been taught in medical school and even in somewhat in specialty training as well, that sleep apnea it's only if you're overweight or have a huge neck kind of situation?
Yes.
How do you think we ended up in this situation as a global society?
I don't know to what extent. There may be limited training. There's no training in dental school for sleep airways. So
no way.
There's going to, that's even today, as far as I know, I don't see there's any training in airway sleep medicine in dental school when we are seeing the source or the cause of it, but the dentists are not being trained to recognize it or screen for it, unfortunately. But I think medicine developed a specialty in sleep. And I think primarily it's awareness, education, clinical practice sort of habits. And just sort of neglecting to think about airway. And there's been good research for children, as you probably know, that if you have behavioral disorders, most notably ADHD, ADD, bedwetting, of course, is part of that, and night terrors. But there are behavioral problems that are tied highly to sleep disordered breathing. But adults, you're right. It's what I've read, of course, is that the delay to diagnosis for sleep apnea is 10 to 15 years between. So there's a very much of a delay. So patients go on having a number of health problems before someone recommends maybe have a sleep study done. Like if you are, I think for psychiatry, it's like if there's a depression disorder or some other disorder, they're supposed to look at sleep as a factor. And so the awareness is up there, but I don't know if it's routinely sleep studies are being done. I think it's growing all the time, fortunately, for the medical community to look at sleep studies, particularly since take-home studies are so much more accurate these days.
So easy. No PS.
So easy, right?
I find, I'd say I was on a group call with a bunch of people in my longevity school the other day, and I think we're talking about it was talking about a certain situation where they should ask about, it's in the guidelines, you should ask about sleep disordered breathing, but then in reality doctors just never do that. It's like 1% of doctors will ask that question, and then 1% will 1% will ask the question and go on to do a proper watch pat or equivalent. I think it's just I think you're right. It's like the sleep physicians will know about it, but there's so few of them that it's not enough soldiers in the army to cover all of the potential cases. So it really has to be like the general dentist, the general practitioner on the medical side level to have a scale effect. Even a hygienist, right, or something. Like I think it's really it's still stuck in sleep physician areas, and then with sleep physicians, they don't know the orthodontics or surgical side of things very well.
That's right.
Unless you're very lucky and you have a guy that is both a dentist and a physician, sleep doctor or orthopedic doctor, and that's very unusual in my experience. And then the orthodontists seem to be the ones leading the way right now, but there's still this huge disconnect between ENTs not knowing about expansion, and they don't know about the nose, and they don't know anything else. And then sleep physicians they just know CPAP a lot of the time, unfortunately. And then orthodontists will, if they're airway orthodontists, they're really good and they'll have a good referral network. That's what I'm seeing, but not always, right? Not your average orthodontist for sure. And then your GP won't do anything. Your general dentist won't do anything. And the oral surgeons, sometimes they're a bit more biased to double jaw surgery than other.
Yes.
So there's there's 10 or so specialties where they're in play here, and they're all except the airway orthodontists, I'd say, they're all lacking in some kind of clinical guideline on on this in their referral practices or their test ordering practices, even their interpretation of 3% versus 4% AHI or
Yes.
even RDI.
Yes. They ignore
A
that
lot of
lot. Yeah. A
patients
lot of
don't know
time.
what RDI
Right.
is, and so on. So yeah, it's like a spaghetti knot um uh, of of what what's that thing in med school? You see the blind men touching the elephant, and each saying it's a different thing.
Right. Right.
It's kind of the
Right. They can
situation. Yeah,
describe the one thing that they touched. Right.
they can see the CPAP, they can see the Invisalign, they can see the MMA double jaw surgery, but they yeah, it's never quite the right perfect situation.
Yes. What's
Yeah,
interesting, I've shown this before in my lectures and so on, but nobody acknowledges the fact that the facial architecture that is developed is subject to progressive remodeling, positive or negative. We often think
mm,
of maybe a 60, 70-year-old
yeah,
person who has poor posture, hunched over, no chin, open mouth habitus, and we think that that's a natural consequence of aging. I would argue that it's the lack of rest oral posture, lip seal, tongue
mm,
fully to palate, which means open mouth breathing during sleep initially and then more and more throughout the daytime as well. And that the jaws actually are regressively remodeling. The jaws are lengthening and dropping down and back. I've
mm,
seen it in my patients before. It's a fact of life that if you don't have good posture of the mouth, even how and you function, you're going to have negative changes. So that to me explains why sleep apnea is a spectrum, sleep disordered breathing is a spectrum, and it doesn't stay the static for the
right,
rest of your life. It's changing and getting worse
yep,
because of other factors, neurological problems with signaling to breathe or
yep,
sensing CO2, O2 levels or whatever it is,
right,
but also because the jaws are changing and the airway is getting worse if
yeah,
you don't have
weaker, floppier,
everything.
lost.
Yeah, the actual bones themselves are negatively remodeled. The maxilla is narrowing and dropping down and back. The mandibles rotating down and back
Mm,
as the person continues to habitually mouth breathe, if during sleep and also during the daytime, so that inevitably the airway is getting more narrow
yep,
and subject to easier collapse. So it's a progressive cycle. There's
mm,
been all of this mewing
yep,
discussed on the internet, and the underlying principle is there. If you have good tongue posture and you're a good nasal breather, if there's negative remodeling, and I've seen it in some of my patients, then
right.
you would expect there to be positive remodeling potential as well. And I
Mm.
think that's true. It all comes down to breathing and tongue position and whether your teeth are together or apart, how you swallow, of course,
So
all affect that.
a tricky thing uh, on the on the pediatric side, and where pediatricians go wrong as well, as an example of another one of these specialties not doing their job, is the tongue ties. So unless there's a huge
Yes.
tongue tie, then if there's a huge tongue tie, it'll be sorted out. But if they're not checking for smaller tongue ties or sleeping tongue posture against the palate, etc. All these other signs of posterior tongue ties that are hard to pick up and so on.
Yes.
So why do you think pediatricians are missing that, or general kind of peds wards doctors, very early after birth? Why are they only focusing on the kind of extreme tongue ties? Is that again like lack of education, or it's not incentivized in some way? What do you think?
Well, I think it's a huge problem, and there's a very large, desperate, if you will, very large range of opinion about whether and when you should do it and why you should do it. The
Mm,
majority of the movement in myofunctional therapy, there is research. It's poor. It's not. It's been growing. It's not a very good body of research, but it has been growing. And I just think there's no consensus about any of it. When and where to do a tongue tie, how to assess for it. So we're left with maybe the lactation consultants, who are assessing newborn latch and newborn
yeah.
breastfeeding. They're aware of it. And in some countries I am aware of, in Brazil, I think, for instance, there's a lot of myofunctional research that's come out of Brazil
Oh.
because they're all of the infants are checked for tongue tie for the sake of proper breastfeeding
Mm,
and encouraging mothers to breastfeed. And there's a lot of effort in that area. it's unfortunate our structure of our culture has limited breastfeeding for the most part. That's another huge problem. If you go back just before the Industrial Revolution, the average time spent in breastfeeding was something like 4 years.
4 years. Oh, wow.
Yes.
Oh, wow.
So there was bonding and there was myofunctional exercise going on
Yeah.
during breastfeeding past the age
Yeah.
of dentition, but it's very valuable to continue to shape the palate, promote nasal breathing, and promote tongue strength to be up in the palate. And now current guidelines from pediatricians are 6 months, all liquid, breastfed or bottle fed. Usually recommendation is finishing at around 1 year.
So, and it's not just the length of time, it's also the vacuum suction strength pressure.
All of that is a massively positive myofunctional exercise that initially develops the palate, and then the tongue has the proper strength to rest up into the palate. That may be a major factor in the deficiency of craniofacial growth we now see in modern industrial Western populations.
So what do you think causes the tongue ties as well?
Yeah, they're midline defects. People have speculated about
HFR?
Yeah, MTHFR defects maybe playing a role, but I haven't seen anything that's a definitive answer as to why that's more prevalent. I guess there's some agreement that it is more prevalent today. Maybe it's being diagnosed more. And there's still yet a huge range of opinion on when and why you would do it. Obviously, during breastfeeding, latching, if you can do an early CO2 laser, minimally invasive tongue tie release, pretty good thing to do to encourage proper breastfeeding and proper latch. But you get into whether or not to do it later on becomes a huge, wide array of different thinking and different opinions about it.
Yeah, apparently I've got a posterior tongue tie, and that's why I can't suction to the roof of my mouth. And then that's why I've had all the breathing issues as well.
Yeah, and we don't, and the posterior tongue tie has been redefined by people like Dr. Zoggy, who's a really forward-thinking ENT leading the charge, if you will, with regard to myofunctional education, awareness, and training. He has a different take on posterior tongue ties, but what they actually are. But you're right, they will limit mobility of the tongue and tongue sealing in the back. And there isn't, I think, a huge consensus on exactly how you would treat it. The technical surgical technique is pretty much the same.
Yeah.
It seems to me the practitioners, I do tongue tie releases as well using Zoggy trained.
Right.
They're backing away from the more deeper, more aggressive types of releases to the more standard releases, and then hoping to get a good result with proper myofunctional coaching afterward.
Yeah, I think that the timing of the release is important as well. If you're going to have some expansion done, people I've spoken to generally say you want to do it after being orthodonticized, as potentially if you do it before, you may not be as strict on the myofunctional habits or the exercises. And maybe you may even have more movement in the tongue that could lead to exacerbation of obstruction.
That's been shown in some early studies that if you do a tongue tie release with sleep disordered breathing present, the tongue actually can go back into the airway further and increase the AHI index.
Exactly.
So yeah, you do have to, and that's a general agreement. I think you want to correct the structure, coach for function. So that's a pretty logical pathway. Address the structure, i.e. skeletal expansion or expansion, and then coach for the function. And then if and when it's indicated, do the release and the follow-up myofunctional strengthening and therapy.
So there's not just a deficiency transversely in the maxilla. There's also an AP aspect as well. And also in the mandible often as well, both transverse and AP. Do you think it's all interconnected, or are there different causes to those kind of 4 different dimensions, or is it all just overall jaw growth that is being stunted by these similar root causes in childhood?
Well, that's a great question. The mandible, generally speaking, is less affected by the undergrowing because the mandible has a connection to the skeletal base via the temporal bones. So as the cranium grows, the mandible grows because of that change to the cranial base. Additionally, the tongue being in the low part of the mouth is typically able to generate more or less adequate stimulation for the growth of the mandible. Generally speaking, the mandible is the victim and the maxilla becomes the culprit, meaning the mandible, from a biological perspective, the body's trying to find a way to fit the lower jaw inside its counterpart. That's a strong biological drive. It's almost hardwired, like a rooting reflex is, like from birth. Neonates have a rooting reflex. It seems to me that the body has such a strong desire to fit the teeth together, even if it at the expense of the airway or the jaw joints, because chewing is a high priority for survival when the dentition appears. So the mandible's reacting, trying to compensate for the underdeveloped maxilla. So it's almost the mandibles, in very few circumstances, yes, you'll have an insufficient mandible, but we think of a class 2 retruded jaw, which is like 60% of malocclusions are like class 2. And the majority of those, when you measure those skeletally, 95% have a normal body corpus length. It's a positional thing. Only 5% have a truly small mandible. In those cases, hypoplastic mandible, where you would actually probably be a candidate for jaw surgery. So we think of class 2 as a problem of the mandible, but in reality, it's a problem primarily of the maxilla and the mandible's reacting to maintain coupling with its defective counterpart.
So the maxilla being small leads to the mandible sitting further back.
Yes, because the mandible's less narrowed. There can be compensations in the alveolar process where the teeth will lingualize or dump in, but the body or the cortical body of the mandible is generally programmed because of the condylar connection to the cranial base. So most of the time, the mandible is, in a sense, wider than the maxilla, its counterpart. And the only way to fit is to pull it back so it fits inside it telescopes inside its defective counterpart, which, by the way, is the majority of our malocclusion problems. Is the maxilla is the culprit. Is the underdeveloped maxilla is the majority of TMJ problems, the origin. And to be honest, it's the majority of problems with the airway.
TMJ as well.
Yeah, because the mandible is compromised in its fit into the maxilla and the joints become compressed as a result.
So if the maxilla was more developed, it means it'd be more forward.
Forward and wider, yes.
And wider.
We have a reference point, by the way, from very good studies from Australian Yuendumu population group, very nice longitudinal studies done in the mid-70s, tracked growth and development for years. And they found the majority of the adult population had, because of their dietary consistency, the maxilla was so large, the mandible could only fit on one side at a time. There was no symmetrical contact. They called it alternating intercuspation, and they felt as though it was a benefit for large, radical, wide strokes to tear food. And yet there's no mention of TMD pathology. So if you reverse that scenario,
that's crazy.
The maxilla is too big for the mandible. You don't have pathology. But if you have the maxilla too small and the mandible, you have pathology. Kind of an interesting way to look at it.
So no Brody bite situation.
Yes, a Brody bite, if the maxilla was in fact too large and the mandible has total freedom of entry-exit and the chew stroke could be wide, there wouldn't be really, at least in that population, they didn't report pathology, headaches, TMJ problems, sleep problems, whatever.
Yeah.
So the maxilla, it even draws your attention more to the mid-facial development status, which is why I've kind of embraced a nutritional component in my reading and my research and thinking. There's a connection between K2 and the growth of the midface, and pretty good evidence in my looking at the research that K2 is more lacking in our diet because of the source origin of our food. And so K2 works with vitamin D and vitamin A to produce matrix GLA protein, which maintains the flexibility of the septum, the cartilage portion of the nasal septum. So if you have premature stiffening of the cartilage, which can be due to a lack of K2, you're going to have a hypoplastic midface. And so if you can access rich spring especially, rich grass-fed green grass, dairy products, cheese, milk, meat, you can get K2, adequate K2 in the diet. Other than that, it's basically seaweed or Japanese natto, fermented soy, but there's really not much access to K2 in our diet. So I recommend to my parents, the patient's parents in my practice, to supplement with vitamin D and vitamin K2. And usually magnesium as well from other reasons. But K2 appears to be partly maybe responsible for the lack of mid-phase growth. There's an interesting way you can prove that by looking at a syndrome called Binder's syndrome, which were unfortunate kids that were born to mothers that took Coumadin, which specifically inhibited K2 pathways, and they have a very depressed mid-phase. So there's a kind of a human experiment.
There's no septal cartilage.
That's right. Because of the lack of K2, you had premature calcification of the septal cartilage. The midface failed to grow properly.
And so what about in this opposite scenario where you got the septal deviation or Z-shaped septum or weird shapes that are blocking airways in the nose? Is this related to the maxilla being too small as well? So like we have a
yes, I think most people would agree anatomically.
And that
if the palate narrows and steepens, you shorten the vertical component of the nasal. Yeah, so you have a nasal septal deviation. And I think there was a study in the UK with newborns. There was a high percentage of deviated septum. They were tracking that. There's now some early evidence about even in utero, people like Kevin Boyd. He's a brilliant pediatric dentist who's lectured and taught and written some things as well. He talks about some in utero effects affecting the growth of the midface and also the jaws. So it's a really interesting issue. He's a great practitioner, brilliant guy. So it's a very interesting problem that has deep connections to going all the way into potentially in utero as well.
Right. Yeah, very interesting. So what I don't understand with that is, so when you expand the maxilla, say with MARPE, and you're potentially giving that more space for the septal cartilage, it's a vertical structure. Is that, well, I guess it's horizontal, isn't it? And vertical. But so what I don't understand is when you expand, you're not lowering. Are you lowering the roof of the maxilla?
Yes. Very, very good evidence has repeatedly shown that the remodeling process will allow that maxilla to come down. The roof of the mouth will tend to move down. I've seen examples of septal cartilage straightening. I don't think it's guaranteed, but I've seen it. And we also build our appliances with space, generally speaking, off the palate, so we can have that effect of the palate forming, the palatal roof coming down as we broaden the palatal process, the shelves or the alveolar process.
Right. Yeah, interesting. Because is that in pediatrics, your appliances that you're using?
Yes.
Adults as well?
Well, so I'm using palatal expanders that are skeletal based in children. Then I'm using MARPE with perhaps only 2 TADs usually in 11 to 13-year-olds now. I was using a Haas type appliance. I just feel like the skeletal effects of MARPE are much improved, and you get parallel opening of the maxillary suture, which improves nasal breathing significantly, as opposed to rapid palatal expansion, which opens a V shaped in the front. And you don't get the posterior nasal cavity changes. So I'm moving more towards doing MARPE for even 10, 11-year-old, 11, 12. Some practitioners are doing it in 7, 8, 9. I mean, the placement of TADs with local anesthetic is pretty atraumatic. It sounds horrible.
It looks
but your mental picture of it is pretty scary, but it's actually very, very atraumatic to do it. And so some are embracing that, and there's good reasons to do that. Although we do know you can open the suture and do a hybrid slow expansion in children and get a very nice result. Everybody agrees there's no debate about that. The question is how much is skeletal and how much is dentoalveolar. And most of the earlier research with RPE, rapid palatal expansion, 60% of the expansion was bending the alveolar process and tipping the teeth. Only 30 to 40%
is tipping as well as the teeth.
So the problem is that's highly unstable, that's subject to relapse, and the nasal cavity is not improved. Nasal breathing is 50% of the total resistance in the airway. And there's good studies that show when you do nasal surgical procedures to improve nasal breathing, you can reduce apnea-hypopnea index quite significantly.
Yeah, for sure.
So you want to have this, and as early as 1902, there were ENTs promoting to their early orthodontic colleagues, they should be doing skeletal expansion because they all saw great improvements in nasal breathing. Children were functioning and sleeping better as a result of palatal expansion and the improvement in nasal breathing. Unfortunately, the orthodontic profession has totally relegated palatal expansion to a lack of space for developing permanent teeth and or a crossbite, rather than saying, no, we want to improve nasal breathing for the sake of airway sleep health, which is the way I look at skeletal palatal expansion.
Likewise. And that's what the studies show as well. And
yes, good studies, very well done, show tremendous improvement to nasal breathing. And then even going back into the early 1900s, there were articles on that very subject. So, I wish we could change our paradigm. When I teach, I say we expand the palate for the sake of the airway, not just for the teeth.
Yeah, exactly. So in terms of order of therapies, so to say, we're looking at potentially expansion first, then tongue tie and myofunctional after the expansion, so you don't get that worsening of the airway potentially. And then after that, looking at anterior jaw surgery and finally rhino-septorhinoplasty. Is that the general order of things that you see? I don't know if that's different for kids versus adults. That's my understanding of the typical order in adults, because your decision matrix is going to change if you've already done expansion before doing jaw surgery, single, double, and nose surgery as well.
Yes, I mean, there's no doubt if you do forward strategies, jaw forward, when we bring the mandible forward, when we do oral appliances for sleep apnea, we can bring the tongue forward and open the airway and have a result that's quite successful in a certain category of cases. So the jaws being forward is going to change the airway, as well as the widening, which brings allows the tongue to come forward. So you can do protraction strategies when you are, particularly the newer research with MARPE, if you dynamically disarticulate the entire circummaxillary sutural complex.
Is that this PS kind of turning protocol? Is that what it's called? Something like that?
Yeah, this is a rapidly evolving area, and we've moved away from, I think most current providers have moved away from the radical rapid technique, which has far too many complications. I mean, my technique now is a sutural loosening technique where I go turns forward and back to loosen that complex and reduce the force on the entire system, and then also slow way down to minimize complications. But when you're in that activated sutural state, you can use a protraction face mask with elastics. And because you're anchoring to bone and you use the elastics that are anchored to bone, you can get some very nice forward movement, but it's patient compliant dependent. We typically think we need 14 hours or more wearing this reverse pull face mask. I tell my adult patients that the window of opportunity maximally is the 12-week period when the sutures are really dynamically active. So I'm not going to advocate that you need to wear this for like a year, because after you finish the expansion, pretty limited results for adults. So I'm focusing on after the suture is open, initiating reverse pull if needed, and doing that for a period of 12 weeks. As much as possible.
Right at the beginning, essentially.
Pretty much after the suture opens, you do a protocol to get the suture moving and open. When you verify it's open, then you know the entire sutural complex is dynamically activated. Then you can get some very nice en masse movement of the mid-face forward. I've seen that in teenagers, mostly adults, hard to do that as well. But yes, if you have a severely hypoplastic mid-face, we can't really change that without jaw surgery. But I think you're right. I think the current thinking would be do the expansion first, both jaws. You normally can do uprighting of the molars and arch development in the lower and skeletal expansion transverse in the upper. You get some forward movement a little bit, the way that the suture opens. And then if need be, you come back and do jaw surgery to bring both jaws forward. That would be like an MMA. That would be for a severe sleep apnea who is CPAP intolerant, say, for example.
Yeah. So with the with this new turning protocol, which loosens all of the circummaxillary sutures, what sort of anterior movements in millimeter terms are you seeing versus just a typical slow MASP style turning protocol?
Well, people have reported on it. I mean, there is going to be some natural opening in the front. We do get parallel opening. If we do it well, we can open at the pterygomaxillary junction sutures and complex, the malar pterygomaxillary, and get some posterior widening, anterior widening. But we think we get a couple millimeters maybe of natural forward progression.
1 to 2.
But the interesting thing is,
turning protocol.
What I'm seeing is that people do this expansion, they create space. The question becomes, how do you close that space? Well, if you use aligners, you're going to have some retraction of that space. It's very hard to control and do pure protraction movements with aligners. I've yet to see that. I'm seeing some very creative things happening, but I prefer to do brackets because I can control and close all space by bringing it forward. So if you widen and then you close, you lose some of that anterior preferred natural migration of the mandible.
In all these cases with the recessed jaws, your teeth, as you see on the CBCT, they're going to be sticking out. They're not vertical or slightly tipped. They're often compensating a lot from the alveolar.
Yes, and if the mandible can reposition forward quite nicely, it will with proper myofunctional assistance. So you can have both jaws forward. And the orthodontic phase 2 needs to be planned carefully, in my opinion, clinically, to protract. I can even protract the molars forward. So the entire maxilla has been, if you open up and you have 4 or 5 millimeters of space all around the arch or more, and you close it, you can bring the entire maxillary dentition forward 2, 3, 4, 5 millimeters, in addition to the skeletal change. And the mandible can propriocept forward if it's properly managed. And have a new posture in a forward position, which then the airway is going to be, it's going back to oral appliances. Well, if the mandible comes forward and the tongue comes forward, the airway is going to function better.
So what is that repositioning of the mandible in terms of, like, how does that happen? Because why don't you just get a 4 or 5 millimeter overbite? And how does the mandible reposition?
Well, this is again a debate within conventional thinking is, well, the mandible's staying where it's going to stay. That's not true. We reposition the mandible for TMJ therapy with TMJ orthotics. Mandible will naturally come forward and stay there if you hold it there long enough. If we do oral appliances, same thing. And orthodontically, the mandible can be coached forward. You have to depropriocept it because the mandible is looking for where there's a bite. So it will stay where it is if you have a bite there. If you do something like a pad on the lower molars to depropriocept the mandible, and with nasal breathing and lip seal and practicing good tongue positioning, the mandible can very quite nicely come forward. And the result will be condylar remodeling. We know there's not growth, but there's remodeling potential in the condylar neck area and condyle itself. It's a specialized form of cartilage that can remodel and create a permanent new bite forward in harmony with the maxilla.
And like you're saying, 95% of people maybe have the raw skeletal length and mass. It's just the position.
That's right. It's positional, not skeletally determined. That's exactly right. So a lot of mandible retrusion is a vertical. So there's one of my mentors in my program made a very brilliant statement that I haven't seen it in other literature, but class 2 malocclusion is a vertical problem. Because if the tongue is laying over the back teeth all the time, when you swallow and when it rests, the back teeth will not erupt and the front teeth will tend to over erupt. So you have the classic deep bite. And again, because of the biological priority for mastication, the mandible will track back to a position that is retruded based on the under eruption of the posterior teeth.
Right.
And when you bring that mandible forward orthodontically, if you erupt that posterior segment, you open the skeletal vertical, the mandible will stay there because that's where the body knows there's a bite there. So a lot of that,
Following the bite.
there's a class 2 vertical problem that needs to be addressed in order for the bite to connect in that forward position eventually.
And that's routinely done with expansion, do you think?
It should be. You can expand, and then the mandible can be postured forward or generally put in a better position. There's some ways you can do that, but then to keep it there, you've got to erupt that posterior. Generally, it's the posterior dentition you erupt up to make contact in that forward position, and then the bite is solidly developed there.
It's elastics, permanent. Is that
typically elastics? Yes, you can erupt teeth
like
quite safely.
You do brackets or braces, and then or like a little screw implant somewhere, and then attach the elastics that way.
Yeah, you can do TADs. We use TADs for a variety of reasons, but yeah, elastics and braces are quite reasonable and very effective at doing that vertical correction.
So, in terms of TMJ issues, which often occur with all these other issues at the same time, when should that be addressed? Is that before the MARPE, or is it during, or before expansion, or during the expansion?
That's a great question. I think most TMJ providers would agree you need to stabilize the disc condyle complex before, because you're going to have damaged ligaments, and you're going to have inflammation, and you're going to have internal derangements that won't necessarily spontaneously correct. So you need to treat that first, allow the ligament complex to heal, the disc to potentially reposition so that it's a non-pathological joint that you can then go into secondary orthodontic procedures.
Right. And what is the treatment for that typically?
Well, I do a neuromuscular protocol, but the idea being you typically have to decompress the condyles because of a lack of posterior vertical. You need to add something that brings the mandible down and forward. That brings the condyle down and forward and opens up functional space that was violated and allow the disc complex to heal. And if possible, recapture the disc, or if it's a serious non-reducing internal derangement, you can allow the complex to heal even without a disc recapture. You can get a pseudo disc, but that process should precede any orthodontic treatment by several months, usually 4 to 7, 8 months of time in TMJ appliance therapy. Preceding the second stage or second phase would be the orthodontic stage. Yes.
So this is a custom molded night guard, or is it one during?
There again, we come into an area of complete lack of consensus about this. I wish we had more of a unified approach, but
that's what I can't figure out.
There's academic oral medicine, university-based training, oral medicine specialty just recently created here, and they believe in a reversible idea where you use a passive or arbitrary splint, you allow the joint disc complex to heal, and you remove the splint and you're done. There's other people that practice orthotic therapy, which is calibrated, customized orthotics to a certain position, and with usually anatomical features that the body perceives there's a bite in that position. The mandible stays there and allows the joint disc to heal. And then you may be able to taper off to, say, nighttime wear and stabilize the complex for a long period of time, but not uncommonly, you would have to go into a second stage to correct the bite orthodontically. And that's a huge part where there's a huge division amongst this academic oral medicine field. They're very against permanent alteration of the dentition, either restoratively or with orthodontics. They don't feel like that's a valid approach. And so they're looking at it as sporadic, intermittent issues with the joint, and you only treat it for a short period of time with splint therapy.
It's tricky, yeah. Everyone seems to have a different way of doing it.
Yes.
So in my case, I have bilateral TMD and a click on my left on opening, which only goes away if I protract the mandible maybe 8 millimeters, a bit less than a centimeter. So I do that, and then there's no click and there's no pain. It feels good. But then is MARPE going to address that by itself, or
no? That's a great point.
Even
the
though
answer
you can
is probably movement? It's sort of an interesting thing. It depends. Is the mandible entrapped because of the narrow maxilla? Because the mandible will come forward on its own spontaneously if you provide the room with skeletal expansion. So part of that answer is yes. And the other part, generally speaking, would be the opportunity to correct the posterior vertical. When that mandible's forward, your back teeth probably don't touch. And so can you correct that component to stabilize that joint? The third component is cranial strain. I treat cranial strains. And so TMD dysfunction can be a matter of the condyles being mispositioned, compressed. Can also be the temporal bones are disoriented and causing the internal derangement. So there are protocols where you can actually unravel the cranial strain, which means you're changing the temporal bone position, which means you're changing the relative disc condyle position within the glenoid fossa that can cause a recovery to happen of a clicking joint. So you've got three levels. You kind of have to look at that.
Yeah. There's no way of knowing which one will work.
Well, it's pretty straightforward. When you look at a facial photograph, you can look at skeletal lines of reference and you can see there are defined patterns of cranial strains. Typically, torsional strains or side bending strains are the ones that I focus on, and those can be identified with a facial analysis photograph.
And that's not a CBCT, just a normal.
It's harder to see it. Yes, conventionally you could, but we typically just from looking at the soft tissues and knowing the skeletal reference points, we can see the occlusal plane and the orbital plane. If they're not parallel, then there's generally a cranial component to that, not just a dental alveolar component.
Yeah. So in general, if you're, in the MARPE, tongue tie release, jaw surgery, nose surgery order of things, you're saying the TMJ it depends on the cause, and it is either done before the expansion or during/after as well.
Well, you can't. It's case dependent. If you have a simple early is the key word. The earlier the click, the more likely the disc is just barely out of position. Typically, anteromedial is the typical direction of that. You can go into braces or orthodontic expansion and probably be okay. But if you have pain symptoms, headaches, neck pain, jaw pain, if you got muscular symptoms, which is TMD, then you want to treat that system and stabilize it first before you go into skeletal, any orthodontic change.
Right. So earlier the better, really.
Yes.
Brilliant. I think we've covered a lot there. I think that's a good introduction to kind of the field for other clinicians listening who are not familiar with things beyond CPAP, so to say.
Right.
For sleep disordered breathing in particular, and TMJ a bit as well. Do you think there's anything else we should cover as we close off?
Oh, you're back. Okay, you're back. No, that's a nice kind of wide sweeping kind of overview of it. Skeletal expansion now, MARPE is it's being much more embraced. It's being done more commonly, which is great. The techniques are refining significantly over the earlier cases, so we're getting better results with more predictable results. And it's really exciting because we know, even though the evidence is there, it's light, but we do know it improves breathing. We're not embracing that. Is this a way to help cure or ameliorate this sleep disorder breathing? But the evidence keeps showing that in fact is happening. And it certainly makes sense in now that we have a way that we can skeletally open that maxillary palatal suture and safely create the necessary width for the jaws to come forward, for the airway to be open, for the tongue to come forward. And it's 90+ of our population is midface deficient, transverse, and sagittal. Wow. And there are some ways to help the sagittal portion, of course, for adults, way better in children, of course. But it's a very good approach and much, much better than what we could do, which is just dental alveolar compensation and pushing teeth through bone, where you could do a little bit and be okay. But the more major amount of it that you need, you can't do it safely.
One last thing on that point as well. Are you familiar with SFOT?
Yes.
Because this is a kind of another common issue, which I personally have as well, where you can't expand. You're limited by the amount of expansion you can do in the maxilla, by the situation of the dental alveolar arch in the mandible. So SFOT helps increase the size of the dental alveolar arch in the mandible to allow you to expand further in the maxilla. So related to that and the sequencing order of all these things, TMJ right at the beginning, nose and jaw surgery right at the end. SFOT, is that whereabouts within the expansion process are you seeing that being done typically, or is there a set time, or does it vary between providers and cases?
I've had it done on a couple of my patients, only about 2 or 3 cases that I have had SFOT done in segments, in the anterior segment, not a full SFOT for rapid development. I'm not as familiar with that research directly. I haven't done much of that. I don't think it's very common if you're doing skeletal-based expansion in the maxilla and you do uprighting in the mandible. You can do most cases without pre-surgical. If you do have a thin biotype, there are grafting techniques. There are connective tissue or cadaver connective tissue grafting techniques to get root coverage. And then you can go a step further and do obviously do cuts in the bone to accelerate bone turnover. That's a very well-known phenomenon of bone accelerated healing. And you can put bone grafting material that can augment that area as well. So I think it definitely has a place when you're doing thin biotype, existing recession. That's what a periodontist would be looking at. And if you can do skeletal on the upper, you probably are safe for the most part. You're not going to have much of any tooth movement if you can. However, on the mandible, you do have very significant limitations on what you can do. If you have to expand, if the mandible is severely narrow, and there are some cases where it may well be that are beyond just the dental alveolar compensation, it gets really hard to correct that. Some people have advocated an osteotomy and doing distraction osteogenesis in front.
MSDO.
Whew, I mean, that's pretty intense stuff, but you can do that, and people have and continue to do that with success to have physical widening of the mandibular basal area to do it too. So that's newer. Less people are doing that. I don't know that the success results, or I know there's complications that occur, but I'm not too familiar with that.
Front teeth and
necrosis, exactly. You lose front teeth, exactly. You nailed it. Yeah, you sacrifice some front teeth in that process of distraction.
I think that's why, from my understanding, if you're doing MSDO, that procedure, you have to have done something like SFOT beforehand to get the maximum benefit and prep as well. So you're saying SFOT, it's kind of like you don't always need it if you have enough uprighting potential for your mandibular teeth. But if you do need it to get a nice wide expansion at the top, then it's done in like a customized way during expansion. Yeah,
so that's a great timing question. So probably you could do the skeletal expansion first. You're not really influencing the attachment here. You can do calm uprighting. You would need to do on the mandibular tissues before uprighting expansion, because you're going to be doing that at the same time you're doing the upper skeletal. So you might have it on the mandibular dentition for the sake of parallel openings, expansion on the lower as well as the upper. So the two arches are coordinated going forward. And then there's the movement of teeth. So you accelerate the movement of teeth. So a lot of times it's done with the express purpose of very rapid movements that are safe, much safer in that highly activated, biologically, metabolically active bone state. So I would think that the timing of that SFOT and then brackets and movement of teeth occur fairly close together. So you can have rapid, quick unraveling of crowded, tipped, rotated teeth.
Yeah. So during the alignment phase.
Yes.
Right. It's also got the benefit of not needing that long-term kind of metal band in to keep your teeth straight, or long-term Invisalign used to keep your teeth straight as well.
Well, I mean, we always, as an orthodontic kind of general consensus, we always want retention, even though it may not be as critical, but we always generally plan on some kind of retention.
Yeah.
Removable or fixed, but retention is built into most orthodontic plans, even without regard to the type of procedure, we want to do retention.
Yeah. Okay. I think we covered most of airway dentistry there in a very light touch introduction.